Today we're going to talk about peripheral arterial disease, which falls under this umbrella of peripheral vascular disease, or PVD. It can be either arterial or venous, so an outflow or an inflow problem, and we're going to look at both, and the management of PAD patients following a revascularization surgery, as well as some health promotion and patient education topics. Looking at the basis of peripheral arterial disease, we're looking at atherosclerosis. Blood flow is disrupted to either the brain, the organs, or limbs. PAD is chronic, it's progressive, and it's a significant indicator for cardiovascular disease. The hallmark symptom of PAD is intermittent claudication. This is severe pain and discomfort with activity. Arteries are unable to carry oxygen-rich blood to tissues and muscles when they need it the most, causing a buildup of acid, causing the pain. Many patients can be asymptomatic or have mild symptoms, while others have progressed to the point where surgical intervention is needed to prevent loss of limb and relief of symptoms. You may find these patients dangling their limbs from their bedside. Unfortunately, PAD goes undiagnosed often. As you can imagine, with peripheral arterial disease, there is severe decrease in ambulatory function and quality of life. That decrease in circulation causes severe pain, delayed healing, wounds, and eventually necrosis, especially in diabetic patients. And they're very high risk for coronary artery disease. When looking at arterial, this is a destination problem. The limbs will likely be hairless, the skin will be dry and thick. You'll have redness and pallor upon positioning, ulcers and lesions. They might be cool to the touch or have weak peripheral pulses, and of course, intermittent claudication. In venous, it's a return problem. Warm, dark, thin skin, venous stasis, edema. You'll have relief with elevation and may have normal pulses. The management of PAD begins with lifestyle. It can also be treated with medications. It's important to have controlled hypertension, controlled hyperlipidemia, glycemic control, and antiplatelet or anticoagulation therapy. If lifestyle and medication management are not effective, or the patient suffers an acute ischemic episode, revascularization surgery could be indicated. There are many types of these revascularization surgeries, and the interventions and priorities should be case-specific. Following revascularization surgery and admission to the unit, a thorough patient handoff is critical, as well as an immediate postoperative assessment. We're focusing on airway, breathing, circulation, mental status, hemodynamic stability, pain, and the surgical site. Interventions we should be prepared for include deep breathing and incentive spirometry. The patient could possibly be NPO for the first postoperative day. Distal pulse sites should be marked and communicated at handoff report. The range of motion of the affected extremity could be limited. Positioning of the extremity is also going to be very important. These are all case specific. The affected limb must be closely monitored for occlusion. Frequently assess pain. Note that pain can be masked by analgesics. The extremity will be checked often, every 15 minutes, then hourly, as ordered by policy. Check capillary refill, peripheral pulses, edema, skin color. Patients must be monitored closely for hypotension and hypovolemia because of increased blood viscosity. When looking at the surgical site and the overall skin integrity of the patient, it's important to understand that they already have a perfusion problem, and it is not appropriate to use tapes or Coban that can restrict blood flow. This applies to the whole patient. Find an alternative. Do not use Coban on IV sites or to help secure topical patches. If you're having trouble with a patch, ensure that you are applying it correctly to clean, hairless skin. This is standard practice, and when not applied correctly, can decrease the efficacy of important medications like nitroglycerin. As we all know, patient education is important to deliver throughout a patient's care. Smoking cessation, nutrition, exercise, and medication regimens should be discussed not just once, but as often as appropriate. Use your best judgment and take opportunities for teaching. Discharge instructions should be clear. They should include deep breathing, incision care, promotion of vasodilation and positioning, home health and physical therapy referrals, and follow-up care. With the prevalence of PAD being what it is, let's help promote awareness and help to screen our patients who might be at risk. Those who are diabetic, have hypertension, use tobacco, or have a family history or possible symptoms should be screened. A non-invasive, easy-to-perform test is the ankle brachial index pressure. If you're not familiar with this, give it a try. Notify the physician of your findings. Compare blood pressures bilaterally as well. A 2016 study revealed that 7% of patients with asymptomatic PAD progressed to symptomatic PAD, and that 21% of patients who were symptomatic went on to have a critical ischemic episode. 6.5 million people aged 40 and over in the United States have peripheral artery disease, and it's estimated that only 10 to 20% of patients are receiving treatment. To promote health and quality in health care, we should focus on education and prevention and early identification. Quality of life is incredibly low, and with timely diagnosis and intervention, our collaborative healthcare team can improve outcomes for patients with or at risk for PAD.